review of the 10-year plan. My name's Paulette Hamilton and I am the acting chair at this moment in time of the committee. So before we go any further, could we ask the panel members to please, not the panel members, the witnesses to introduce themselves. Can I start with yourself, Wes?
I'm Wes Streeting, I'm the Secretary of State for Health and Social Care.
I'm Sally Warren, the Director General for the 10-year plan at the Department of Health and Social Care.
Jim Mackey, Chief Exec, NHS England.
Okay, brilliant. So you've got me for the first question. So let me just ask you this particular question. And I'd like, Wes, if you could answer first, if there are any bits that we're missing. Sorry, before I do that, Wes, do you want to give a little taster, before I start my questions, do you want to do like a bit of an overview so that we can get a bit of a warm-up? What's wrong with you today? Are you nervous, Wes?
Yeah, you're in the chair. Look, first of all, can I just begin by thanking the committee for all of the contributions you've made to the development of the 10-year plan through your inquiries and evidence, particularly into the first 1,000 days, community mental health services and healthy ageing. And we're looking forward to working with the committee in the coming months and years, both to hold us to account for the delivery of the 10-year plan, because I think it's fair to say that the reception to the plan has been extremely positive. The question everyone asks is, are you going to deliver? Which, given people's trust in politics and politicians, is not a surprising question, but it's one we definitely need to answer in the affirmative. I'm really proud of the way we've built the 10-year plan, not just taking on board the views of the committee, but having what I think is the biggest national conversation since the NHS was founded about its future. We received 250,000 responses through the Change NHS website. There are over 600 in-person events right across the country. They involved the people working in the NHS as well as the people who use the NHS. I'd just like to say a big thank you to all of our colleagues across the House who hosted 50 events with constituents across the country. And what we found, of course, is that people are extremely anxious about the NHS and its future. They feel that sense of jeopardy. And there isn't a single person using the NHS or working in the NHS who would say the National Health Service as it is today needs to stay exactly the same and exactly where it is. Everyone can see the scale of the challenge, and people want to see the NHS fulfilling its founding promise, which is to be there for everyone when they need it, and to do so in a way that defends the equitable principles at the founding of the NHS, the principle that healthcare should be based on need and not the ability to pay. We know the challenges are going to get harder, particularly with our growing ageing society and rising levels of chronic disease. And I was struck through the public engagement at the extent to which the general public wanted to talk about public health and prevention, not simply the service itself, which is encouraging because we're going to need their help to create a fairer and healthier nation. We inherited record waiting lists, the lowest ever levels of patient satisfaction, staff burned out and walking away. And all of those things, I think, fuel that sense of jeopardy that people feel about the NHS's future. But there are also grounds for optimism. This country is one of the world leaders in life sciences and medical technology. We need to make sure that we are not just benefiting from that revolution, but actively driving it and making sure that those innovations are being adopted and rolled out consistently across the NHS. We know that thanks to the decisions taken by the Chancellor, the NHS has been the relative winner at the budget and spending review. So this is a funded plan for the next few years, and that sense of medium-term certainty will help the system to deliver and design their services in a better way. I think the thing that is fundamentally different is about how we imagine the NHS working in the future. At the moment, the NHS is a very centralised, top-down state bureaucracy. The NHS of the future needs to be one where power is devolved, where there is far more freedom to the front line. We've got some brilliant people working at the front line. We've got some brilliant leadership capability throughout the NHS. We need to set them free to do the job as well as holding them to account. And finally, the most important revolution of all, as far as I'm concerned, is the revolution needed in patient power. When Nye Bevan established the NHS in 1948, he said he wanted it to hold a megaphone up to the mouth of every patient. But the NHS that we see today is a far cry from that vision. Patient voices are too often unheard, their complaints dismissed or discouraged, and the NHS needs to move with the times. Patients need to have far more ease, convenience, choice and control over their healthcare, and that's at the centre of the plan.
Fantastic. So that goes very nicely into the first question that I want to ask. You've talked about the 3 shifts at the core of the plan and the long-standing ambitions, but Wes, we have seen these in multiple NHS strategies, for at least the last 30 years. So the question I'd like to ask you is, why do you feel this plan will succeed when so many others have failed?
Yeah, it's a very good question. You're right, the 3 shifts were not in themselves radical new ideas, but delivering them really would be. Why now and not before? I think there are a few things in our favour. The first is the sense of jeopardy that the public feel about the future of the NHS is felt right throughout the service. We've prosecuted an argument in opposition and now in government that it's change or bust, reform or die, and I think that there is overwhelming consensus in that direction. People in the NHS want to see it change, they know it needs to change, and they are up for it. Secondly, how we do the change is as important as what the change is, because if you think, thinking about some of the things contained in the plan, whether they're new models of service delivery, new commissioning arrangements, new innovation in terms of medical science and technology, we will only succeed in delivering this plan if we're doing change with people rather than to them. And that's why, in terms of how we've approached some of the challenges as a government so far and how we will deliver this plan, we will make sure that the implementation is designed with as well as delivered with people throughout the system. And already, Jim may want to say more about this, we've had people banging down the door since the plan was launched saying, we're really interested in this new model of neighbourhood health, we want to go first. We're really interested in the reinvigorated foundation trust model. How can we have a piece of that action? These integrated health organisations, how can I be part of it? And that's exciting for me because we can get those people.
Bring Jim in now, that he can just finish that off?
Yeah, so just Jim, to add to that, we had a chief execs gathering on Thursday where we've created some groups to develop the next parts of the plan on neighbourhood health, integrated health organisations, the medium-term planning and financial rules. So a handful of bits of work, the NHS app, etc. Really strong engagement. So the last count, this is still moving, are about 120 volunteers for chief execs and their organisations to participate and want to get out in front. I've actually just left a call with a colleague ahead of a session later on where Secretary of State's pointed out there's this real tension of real ambition and desire to get out and start delivering this stuff at pace, a will to work in a new way, but also wanting more detail. And we just got to get that balance right and hold our nerve on, we'll develop the detail with colleagues in the service because that'll work better and it'll give us a better chance of success. So that's really what the next few weeks are about.
So what do you feel has been, from the previous attempts we've tried at reforming, what do you feel we've learned from those previous attempts that we can bring in to this particular reform?
So I think the worst thing we could do is to take the plan and the end state that we're aiming towards and try and impose it all in one go now. I think the lesson of the Lansley reforms is that a big top-down reorganisation imposed on the system doesn't work. And, when you follow through the logic of some of what Andrew Lansley was saying, I could see the method in his madness, but the execution was really poorly done, and some of the ideas at the outset were ill-conceived. And I know we've taken a bit of flack for the fact that we did a big engagement exercise to build the plan, And we will take some flack for the fact we're working with people on designing implementation, but that is a far, far better approach than the alternatives that we've seen. And I think the other thing to that point as well, with some of the models we're going to roll out, particularly think about primary care, like the principle is you set people free to lead the path to the future, to show us how the new model will work, to be the early adopters and the pioneers, and in doing so inspire other people to follow. And doing that in a way that doesn't go in like a bull in a china shop and say to a primary care network, for example, although you're working really well and you're driving innovation and you can demonstrate year-on-year improvements, we, the government in Whitehall, have decided that we don't like your model, we're going for a different one, and we're just going to go in, like a bull in a china shop through your thing that's working. So we're not interested in going in and bulldozing through things that are working in pursuit of the thing that we think will be the future. Far better to let people themselves opt to be the pioneers, to show how it will work in practice, and then inspire other people to follow.
Really good place to stop there. So my next question is relating to dentistry. And last week we had Minister Kinnock, who told the committee funding for dentistry was likely to be in the region of the current financial envelope. Given the ambitions and the plans you have to reform NHS dentistry, why have you not committed to increasing the dentistry funding to pre-pandemic levels? Will you be reconsidering your decision?
Well, so a few things in response to that. The first thing we could do is make sure that we are making the most of the money that's already going in. And in opposition, we complained a lot about dentistry underspends. And one of the ways in which we'll be looking to address that, obviously some of the things we're already doing, the 700,000 urgent appointments that are being rolled out, but we know that fundamental contract reform is needed. There is a tension, there is a constant tension for me between the level of ambition we have as a government, the level of demand put on us by the Parliament and the public, and the choices and trade-offs that we face when trying to deal with an NHS that has such a breadth and depth of challenges. So,
Wes, let me stop you there, because you could talk for another 5 minutes and I haven't got 5 minutes. Will you be considering that decision?
I said I was scared of you during this meeting.
Shut up, Wes. Will you be reconsidering it?
Look, it is something we are constantly put under pressure on from Parliament and the public. We will do as much as we can, as fast as we can on NHS dentistry.
Absolutely awesome. And my final question is around palliative care. So, palliative care does not feature significantly in the 10-year plan. What I've noticed is it's been mentioned, I think, about 4 times with all the experts that have trolled through it. And also in the index, you mentioned something about palliative care, but it wasn't actually, nothing was said on palliative care. With all the issues we've now got to address inequalities, we're looking at palliative care through the 10-year plan, also through the context of the terminally ill. How are you planning to address palliative care going forward? Because that is becoming, I'm going to use the word from last week, a burning platform.
Yeah, so palliative care does feature, particularly in the context of neighbourhood health services, and I feel very strongly, and having seen palliative care in a range of settings and frankly a range of quality of provision, the principle we want to see in palliative care is the same as the rest of the NHS, which is giving people real choice over the care they receive, when they receive it and where they receive it. And for some people that'll be in hospices, for some people that'll be the comfort of their own home. Wherever possible, we'd prefer it to be the latter, but that won't be right for everyone. We've obviously taken some steps already in our first year with £100 million for hospices through capital investment, which has been used to good effect to either expand or modernise estates, or often buy the kit that's necessary to provide good hospice at home care. And the £26 million children hospice grant, I know, has made a real difference as well.
Whereas if we talk to the sector, what they're saying is they've used over 70 million of that 100 million to do the national insurance payments. So it's only left them with, I think, about 24 million. This is what they're telling me. And what they've said is this is going to become a burning platform in months to come, because that money is running out, and some of the organisations are actually saying now that they will be closed in the next 6 months to a year if they don't get the support they need.
So I'd say, I've never been comfortable with the extent to which hospices are reliant on the generosity of the public through donations to fund something that I think in today's day and age is an integral part of the health and social care system. What I can't do with the scale of the challenge that we currently stare into and the pressures on the public finances commit to moving us as far down that route to state funding as I would like. So in the meantime, I think, certainly we will continue to do everything we can through state investment. I indicated at a reception recently for Havens House Children's Hospices, which serves my constituency, and we had Hospice UK and Together for Short Lives and other amazing charities there. I think it's worth us looking at what we can do with the sector to see if we can leverage in more support through things like match funding and other schemes to try and get more investment into the sector. So we're open to those sorts of conversations.
And I know they appreciate that. So my last point would be, when will you start considering working with the sector to look at a new strategy, read the way forward? Because that was talked about last year, and the sector really do want to work with the government, like many others, to just get to that point where they feel as if they're being heard and being inclusive. So how long will we be looking at the government really starting to work with this sector? And it just needs to be a few words.
Yeah, and we do engage with the sector. I will certainly pick up your line of inquiry with them. But the second thing, I know there's been an initiative for a commission on end-of-life care, which has been established. It's independent of government. We'll be following their work carefully and looking at what they recommend as well.
Thank you, Wes. Can I hand you straight over to my second committee member, and it's Joe Robinson.
Afternoon, Secretary of State. I'm going to stick with some of the bigger themes that we dealt with at the beginning. In fact, you've already touched on some of them. And I'm going to quote, "Investment has to be accompanied by reform. The NHS has to be redesigned around the needs of the patient. Local hospitals cannot be run from Whitehall. There will be a new relationship between the department and the NHS, etc." Presumably that's an underpinning principle that leads to things like a decision to abolish NHS England.
Yeah, that's absolutely right. And what we're trying to do is a few things. One is to shrink the size of the centre, make its focus more strategic and holding the system to account on outcomes, and devolving as much power, resource and responsibility closer to the front line and at the front line as we possibly can. We also want to make sure that our financial flows and incentives are aligned with our public policy objectives. So, because if there's one thing I've learned about this system in the last few years that I've been in this portfolio, is that money talks. And if you get your incentives aligned or indeed misaligned, you either get the desired outcomes or the completely unintended outcomes. And that's why working with the system on the design of those is going to be really important. We also want to make sure through the technology and innovation side that we've got a big focus on productivity, because it's one of the big challenges, not just for the NHS, but given the size of the NHS, it's a challenge for the British economy.
Just try another one.
The NHS is as productive as possible.
Yeah, can I try another one, which I hope you'll agree is a theme, a different theme, but nevertheless a theme. So, quote, "The NHS has been too slow to change in its ways of working to meet modern patient expectations for fast, convenient, 24-hour personalised care. Changes in primary care will help ease the pressure on hospitals so that they can concentrate on providing specialist care." I mean, that, presumably in a nutshell, is the shift from hospital to community.
Completely agree.
Yeah. So my concern is that absolutely none of this is new. Well-meaning, well-intentioned, but none of it new, because the two quotes I've just given you are actually lifted directly from Alan Milburn's NHS plan in the year 2000.
And that plan delivered the shortest waiting times and the highest patient satisfaction in history, so it sounds like we're on the right track. But there's lots of stuff in the plan.
Is this a back to the future? Are you Doc Brown taking us back to the year 2000 to sort out the NHS?
No, I've not gone that grey in this job yet. But I think the themes are, as I think we said in response to the chair's questioning, like the shifts themselves are not new ideas. Delivering them in practice in this NHS really would be. And there are lots of things contained within the plan that are new models, new ways of working, a new approach to innovation, adoption and rollout. So there's plenty of things in there on the prevention side that are novel and innovative, as well as things that are well evidenced and need to be rolled out more consistently.
Perhaps you can help. What's the difference between community diagnostic centres, multidisciplinary GP surgeries, DARSI centres, and now, your word for it, neighbourhood hubs? I mean, these are things that have run from the year 2000, 2008, 2012, and now your plan. They sound like the same thing, just with different names. Your name is neighbourhood hubs. Perhaps you can start by telling us how that's different from community diagnostic centres or DARSI centres from 2008.
Well, DARSI centres, or polyclinics as they were known, were effectively strangled at birth. There are still a few around, but it was a source of huge controversy at the time for something that I think, as an approach, I think people agree doing neighbourhood health and population health at scale is a good thing to do, and that was certainly borne out through the consultation. Community diagnostic centres are by definition diagnostic centres, and what neighbourhood health centres will do is bring under one roof a whole range of different services to give patients a one-stop shop with the principle that anything that can be done outside of a hospital setting in communities, in neighbourhoods, should be. Hospitals should be for the most serious cases, complicated procedures, operations. What we want to see happening in neighbourhoods is the opportunity to go in and get much faster access to consultations and diagnostics, to be able to have things like your blood tests, scans, all under one roof. Minor injuries, urgent treatment centres, all of that can be done in primary care. And the reason we know that to be true is because in pockets of exceptional practice in this country, it's already happening. And one of the core themes of the plan is to take the best of the NHS to the rest of the NHS. When
Tony Blair and Alan Milburn were doing this in the 2000s, like you said, it delivered the sort of healthcare that you'd like to see. They were spending 6.8% increase year on year on health. You and Rachel Reeves have got a plan to spend 2.7% according to the last budget. So how are you going to deliver spending historically low figures? In fact, 2.7% is lower than the 3.5% of the last Conservative government. I'm just interested as how you're going to pay for this.
Well, it's why investment needs to be matched with reform. And the economic circumstances were very different for the last Labour government. This is a government that has to live within its means. But as I've argued for some time, the NHS has become more bloated. There is waste in the NHS. And the last government is a good kind of case in point as to why you can't just throw money at the problem. Because if it was a case of just throwing money at the problem solves the problem, the last Conservative government should have had a decent run at it. They poured quite a lot more money into our hospitals, significantly expanded staff in our hospitals, and you would think with the pressure hospitals are under, sensible thing, right? Except that all of the congestion caused in hospitals finds its route outside. So it's either people can't get the right primary care, or they can't get access to primary care soon enough, or care in the community, so they end up going through the front door of the hospital, either in an emergency department or onto an elective list in a far worse condition they would otherwise have been in had someone got to them sooner. Or they're then stuck in a hospital bed and can't get out because there either isn't the social care or community care bed capacity available. And so what we're doing is a system-wide approach that recognises that if you want to improve the flow of patients through hospital and everything from your A&E waits, your elective times, delayed discharge performance, you've got to deal with primary care to deal with the problems at the front door, and you need to deal with social and community care to deal with the problems at the exit door, put crudely.
If we take this plan, which is a set of good aims, as we've agreed, there's nothing hugely revolutionary or radical there in terms of the overarching themes. My view is the one opportunity you've got to succeed where perhaps other governments have only partially succeeded is the delivery, is how do we do the change? But there's so little in here about how you're going to deliver. So perhaps you can tell us how to get to the end point, which is in this document. And if you can tell us about that, where can we see it written down? I'd like assurances it's not still only in your head.
No, we'll keep coming back to you as a committee as well. But look, this comes back to the very first line of questioning, which is there is a way of doing this, which is imposition of change, or there's a way of doing this which is about taking people with you. So on everything from the new governance arrangements for the reinvigorated foundation trust model, to how integrated health organisations will work, to how we'll deliver neighbourhood health, we'll be doing that with system leaders. We'll be setting some people free to go faster than everyone else and to show us what the future looks like. And then others will follow.
And the Chancellor's on board with the money?
She is, yep.
Good to hear.
And the budget and the spending review. And I know that the public finances are under pressure. That's why I was sensible enough to bring the Chancellor to the launch of the plan.
Thank you. Thank you, Secretary of State.
Oh, thank you for that, Joe. Can we go swiftly over to Becky, please?
Thank you, Chair, and thank you for coming along today, Secretary of State, Sally and Sir Jim. If we can move on to population and public health, please. So if we continue your theme, Secretary of State, about money talking, could you please outline to the committee how the finances are going to align with your sickness to prevention shift? And specifically, in 10 years' time, what percentage change should we expect to see in these areas?
Oh, I'm definitely not going to write the budget for 10 years down the line.
But would we expect to see a change, Secretary of State, in terms of the shift from sickness to prevention and the money following it?
Yeah, and look, over time, what we want to do is see far less spent on the price of failure. And, obesity costs the NHS 7.3 billion a year, alcohol 4.9 billion a year, tobacco still, despite all the progress we've made, 1.9 billion. Economic inactivity due to sickness. In the NHS, 2 billion cost to the economy. So you can see sort of right across the board we're paying a very high price for failure. What we've set out in the plan are a number of approaches, some of which you would consider a sort of conventional public health, and obviously we've got the tobacco and vapes bill going through Parliament, which in terms of the impact and benefit of the policy would provide the NHS with £6.6 billion worth of savings, and we're going to go further by clamping down on vaping of young people. But then there are kind of more radical approaches. So what we're proposing is to do with supermarkets, for example, to improve the nutritional value of the average shop. I don't think has been tried anywhere else in the world. The genesis of the policy was an idea from Nesta, who we've worked with to develop that policy. We've got a number of the big supermarkets on board. And taking that approach will lead to a very different sort of approach, not just from the state, but from the food and drink industry as well.
OK, Secretary, so perhaps we'll go straight to that then. So a voluntary arrangement with large food companies has been tried before under the previous administration. Prime Minister Cameron tried this and yielded very poor results. In fact, the only evidence-based increase really was around the legislative food tax. So how is this voluntary agreement going to be different to previous voluntary agreements?
Well, the reporting and the target would be mandatory. We want to work with the industry to get it right. So it's not in any of our interests for it to fail. But the data on the food and the drink that we buy from supermarkets is already held by them. It's some of the best public health data in the world. They had already been calling on us to publish the data. And so that's the bit we should look to do with them most quickly. But then I think we should work with the industry to set a target for improving the nutritional value of the average trolley or basket.
Okay, and I agree, the public health data are good, but I'm sure that you're aware that in terms of socioeconomically deprived areas, there is a substantive number of our population who do not access their food and their nutrition through supermarkets. And therefore, how is this particular initiative going to address those inequalities? And if it's not, how are you looking at the nutrition of people who are in what we call food deserts, where they're accessing their foods through smaller shops, etc.?
So 85% of our shops come from supermarkets. I take the point you're making about the exceptions and some of the areas of the highest levels of deprivation. But I don't think we should let perfect be the enemy of the good. I
agree, Secretary of State, but in terms of proportionate universalism, if you were going to put your investment into a place that would make a substantive difference, would you not agree that you would put it into the most deprived areas to see that improvement, which I think actually is your aim in your 10-year strategy?
Yeah, and that's why in a speech in Blackpool recently, I announced our determination to change our funding formula for investment in public health to target those areas of highest level of need and deprivation. We'll be taking a similar approach to reform of the Cahill formula for general practice. I think it's a disgrace, frankly, that if you are living in the poorest community in the country, there'll be about 300 more patients per head than the most affluent, so it's the inverse care law, like writ large. But the supermarkets thing is significant because by setting the target in the way that we will and actually giving industry the freedom to innovate, I think we will see things like loss leaders and price promotions on the healthiest products. I think we will see supermarkets thinking more creatively and ethically about their marketing practices, the layouts of their shops, and the wonderful thing about this approach we're proposing, if we get it right, is actually it will lead to less nanny statism, ironically. Because rather than having the Secretary of State trying to dictate, price points, promotions, location of the chocolate in the supermarkets, and anything else that I might be tempted to meddle in to make the nation healthier, if supermarkets are driving towards the goal of more nutritious sales, they will know their customers best. They will know what works well in terms of nudging people in the right direction, and that's why I think this sort of partnership approach, I think, is I think the third way between kind of nanny statism on one hand and being very directional, or kind of just taking a step back and being completely laissez-faire about it.
Okay, so I look forward to seeing how the choice architecture improves our lives. The data so far don't back it up, but I very much hope that you're correct. Can I go to something that perhaps is more directional, which is alcohol, which you mentioned, the cost of alcohol to the National Health Service and to people's lives. So could I ask why in this 10-year strategy we are not making a commitment to set a minimum unit price when the available evidence shows that this is an effective way of reducing harmful alcohol intake?
Minimum unit pricing, I know that there is a loud campaign in favour of minimum unit pricing. That's not something the government has chosen to proceed with at this time. I'm sure there'll be a healthy debate on that in Parliament. What we are proposing to do is give the consumer more health information. It is a bit daft that you can, get more nutritional information about a can of fizzy drink or a packet of crisps on the shelf in the supermarket, but when it comes to the number of calories in a pint versus a gin and tonic or a gin and slim versus a glass of wine, we don't make that information available to consumers, and I think we really ought to. We do need to go further on tackling what I would describe as problem drinking. 4% of people drink as much as 30% of the alcohol consumed each year, and they do that at serious consequences to their own health and sometimes to the detriment of their own lives. And that is the issue I think we need to, with the whole sector, have a more focused approach to tackling.
Okay, so I look forward to that robust debate on minimum unit pricing. Perhaps moving on to something else that is also in our legislative agenda, which is the junk food advertising ban before the watershed. Could you explain why that's being delayed, please?
Well, it's still it's coming in from the new year, there were perfectly reasonable, legitimate concerns about going as fast as we were proposing to.
Sorry, Secretary of State, what were they?
The readiness of the industry to comply and the way in which the regulations would be subject to potentially misinterpretation. So I think it's fair to say the industry, they know it's coming. It's definitely happening. There's no wriggling out of it. And actually what you'll see in the run-up to Christmas is widespread compliance. But there was I think a reasonable debate about brand advertising versus product advertising, and we wanted to work with people through those issues so that the law actually works in practice rather than catches people up with laws of unintended consequences. So that's the only reason for that delay, but you should still see widespread compliance.
Okay, and just to explain, if you can, around the branding issue, so is the conversation that you can't show the product per se, so the food product, but the argument from the industry is that they should be allowed to advertise their brand? Is that the argument that's going on?
In a nutshell.
Okay, and do you have a sense about where that's going to land yet or not?
We'll keep you updated.
Okay, thank you. And my final question is around the health mission. So obviously the National Health Service, it's great that it's going to be a National Health Service again, but I know that you're all too aware that health in and of itself is it should be a mission across all the directorates and into local authorities. So I just wanted to ask, it's gone quite quiet, is the health mission still alive? And if so, how is it shaping the broader health prevention agenda with this 10-year strategy? And if it's, died a death, who and how is are now shaping this very important issue across the relevant directorates?
No, it's still very much alive, and one of the things that is working really well in the health mission is the way in which we're firstly galvanising other government departments behind the focus on public health and prevention. So on this policy I mentioned on supermarkets, for example, would not have been possible without the joint working between my department and DEFRA and the support of Steve Reed, the Environment Secretary. Similarly, the work that Lisa Nandy is doing to try and reorientate our cultural and sporting offer to underserved working class communities with high levels of deprivation need across the country, very much aligned with the health mission. Bridget Phillipson's work on not just expanding free school meals and breakfast clubs, but making sure they are nutritional. The work that we're doing in partnership with DFE and DCMS on school sports and making sure we've got qualified PE teachers, upskilling education on PE and games in our schools, all really important stuff. And there's a whole load of stuff just like that that's coming together under the health mission. But we're also
Secretary of State, is housing and air quality, are they there and live?
Yeah, look, one of the things that is exciting about the Deputy Prime Minister's commitment to build 1.5 million new homes is that one of the biggest challenges we see are the number of children living in temporary bed and breakfast accommodation, not able to have decent space to live and learn and play, often in accommodation that doesn't even have basic cooking facilities, and so the takeaway is the only option. All of those things, all of the social determinants of ill health, that is what we as a government are committed to tackling. And moreover, we can't do this as government alone. We need to work with business and civil society, the private sector and the voluntary sector, to bring all of this to life, and that's exactly what we're doing. The supermarkets policy is a good example of working with the private sector. We've got an exciting collaboration which is coming out tomorrow to get more young people kind of physically active and engaged to tackle the issue of obesity amongst primary age children. So you can expect much more of this sort of stuff coming out of government in partnership with business and civil society.
Great, and just to say that obviously the public health workforce is a key part of this. I appreciate that they don't sit all in the national health system, they sit in local authorities and in different places. I note that there's not a specific plan around the public health workforce per se yet, so presumably will that be looked at in partnership with local authorities?
Yeah, I very much see, especially as a former Cabinet Minister for Health and Wellbeing and Local Government, I very much see DPHs and the public health team as part of our team. And we're improving all the time the relationship between my department and Directors of Adult Social Services and Directors of Public Health, as well as elected members as well. And one of the things what I'm committed to doing with the LGA is, as part of the delivery of the 10-year plan, making sure that we've got much stronger institutional relationships, not just between Whitehall and communities across the country, but also across communities between the NHS, local government, and social care and the voluntary sector as well.
Thank you.
Thank you, Becky. Straight over to you, Alex.
Thank you, Chair. Thank you, Secretary of State, for your answer so far. Just to carry on the theme from Becky's questioning. I know what you say about the supermarkets holding a lot of data, and it strikes me that another group of organisations that will have an awful lot of data about our eating habits is the delivery companies, Deliveroo's and Just Eats of this world. Is there any work the department's doing that is thinking about maybe bringing them into a similar type of arrangement that we have, that you're suggesting with the supermarkets, so that we can tackle the takeaways and the slightly less healthy food habits that some of us might have?
Yeah, I think the out-of-home sector has got a role to play, and I think you're right, and this is potentially the way in which we can help to improve the picture in the SME part of the sector. Like, government, rightly in my view, takes a much more cautious approach when it comes to regulation of your small businesses, and we recognise that asking people to do things like calorie labelling or menus or other changes to how their business runs comes at a cost, and for some businesses complexity that they can't afford, and we don't, especially the pressures on our high street, especially the pressures in the economy, we don't want to make life harder for small businesses. And look, I enjoy takeaway as much as anyone else, so on all of these things I'm not coming at this from the point of view of being the fun police, as one or two drivers to my house would attest when they're dropping off my takeaway. But those sorts of platforms like Uber Eats, like Deliveroo, they do actually have a lot of really valuable information about their customers' eating habits and about the food that's being sold through their partners in the sector as well. So I think it's fair to say they've got a different starting point to the supermarkets, but we are absolutely committed to working with the out-of-home sector.
Great, thank you. I'm going to move swiftly on, given timing. You mentioned in your response to the Chair some of the criticism about going through a period of consultation. I guess what did you learn from the consultation on the 10-year plan that you didn't know before you started?
Oh, loads of stuff. I mean, even on prevention, we sort of went in asking questions very much about the NHS. And I know that the public do care about health and well-being more generally, but we didn't expect the sort of visceral reaction we got from people who were saying, if you're not doing public health and if you're not doing prevention, then this plan isn't going to work. So there was a real awareness on that and pressure from the public, which I think is really important, especially in a political context where we're often kind of told that, doing stuff on public health kind of gets kind of resistance from the public. Actually, a lot of what we heard was, help us make healthier choices, help us make easier choices, help make activity more affordable. I think the other thing that we learned, if you take the technology side of things, both from the public and staff side of things, people instinctively get it, particularly in the amongst NHS staff. Lots of them are scientists. So they're really excited and aware of and enthusiastic about AI, machine learning, data, genomics, and all of the other stuff that's going to completely change the paradigm of health in this country and around the world this century. But what they were often saying to me directly, as well as through the engagement exercise we did, is it's all very exciting. I can't even get my machine to turn on reliably in the morning. I'm using 7 different passwords to log on to deal with a single patient. And so kind of what we learned there is that if you get the basics right, you'll get a lot of trust for the stuff that follows. And I'm amazed that this hasn't made more front pages or grabbed the headlines, but our commitment in 2026, 2027 to give all staff a single login to deal with the 7 passwords issue, I mean, I can't believe that has not been greeted with a level of fanfare as some of the other ideas in the 10-year plan. But actually, in all seriousness, it's really important because it will prove to staff, to the point that Joe was asking about and the Chair was asking about. You've got, I think, a lot of people out there that are willing us to succeed but are still sceptical about whether some of these things are going to happen. Sure. So the more we can prove more quickly, I think the more momentum we'll build behind the plan.
Great. And moving on to workforce, obviously workforce can be very key in delivering this 10-year plan, and it would be remiss of me not to take this opportunity to ask you about the strike, threatened strike action from the BMA. Could you update the committee on the progress you've made on securing a meeting with the BMA's Resident Doctors Committee?
Yeah, so I'm pleased to report that the BMA have taken up my offer of meeting this week. So we will be meeting to see if we can find a way to avert strike action. I have to be clear with the committee, as I was with the House last week, that there is no more room for manoeuvre on pay, but there are lots of other things that we can do and should do that would lead to material improvements to resident doctors' lives now and into the future, including on progression. But these things are always choices and trade-offs. Lots of things that resident doctors are asking for in terms of things like doctor unemployment or progression into specialty posts, both of which I agree with them on. They do cost money. Many of the other things that we want to do in the NHS cost money. And that's why going on strike, having received a 28.9% pay increase, is not only unreasonable and unnecessary, given the progress that we've been making on pay and other issues, it's also self-defeating because it will come at a cost of the things that we want to invest in to improve the NHS. And at a time when the NHS is moving in the right direction, when waiting lists are falling, GP numbers are going up, and people are feeling a sense of cautious optimism about the NHS's future, I think it would be a catastrophic mistake for the BMA to throw all of that progress into reverse by walking out on strike. The public don't support it. Even a majority of resident doctors didn't vote for it. So I hope that when we meet, we can see a way through this that avoids the misery that will be inflicted, not just on patients, most importantly, but also on other NHS staff and the future of the NHS.
Thank you, Secretary of State. And in terms of, obviously, they've announced an initial 5-day strike. If that was to go ahead, what assessments has the Department done on what the impact that might have on elective waiting lists?
Well, actually, I should probably bring in Jim as well on operational planning, but I'd just say a couple of things. We can mitigate against the impact of strikes, and we will, but what we can't do is promise that there will be no consequence and no delay, no further suffering, because there are lots of people whose procedures are scheduled over that weekend period and in the period subsequently where the NHS has to recover from the industrial action, who will see their operations and appointments delayed. I have a relative in that position. My family are currently dreading what I fear is an inevitable phone call saying that there is going to be a delay to this procedure, and I just think this is an unconscionable thing to do to the public, not least given the 28.9% pay rise. The other thing that I have found actually shockingly irresponsible about the BMA's position is their leaders seem to be telling their members not to inform their trusts or their employers if they're going out on strike. Now, I might not agree with the BMA's strike action, but I do accept they have a right to strike. I do accept they've followed the rules in order to go on strike. What I cannot fathom is how any doctor in good conscience would make it harder for managers to make sure we have safe staffing levels, would make it harder for other staff who are going to be turning up to work that day, not least the staff who have not had a higher percentage pay rise, many of whom are paid less than resident doctors. So I just think the sort of the BMA's approach to this from start to finish has been completely wrong. They started off a year ago with an incoming government that had an enormous amount of goodwill towards them, an enormous amount of sympathy for the arguments they were making. and work quickly to resolve those strikes. And not just a deal to end those strikes, but the opening up of a partnership where we could work together to improve the NHS. And instead of working in partnership, they've chosen confrontation. It's not too late, even at this late stage, for us to get back on the path I wanted us to be on, of working together, of driving real improvements for resident doctors and for patients, but it is going to require a different mindset. The government's changed, the policy's changed, it's time for the BMA's tactics to change. And the idea that doctors would go on strike without informing their employer, not allowing planning for safe staffing, I think is unconscionable, and I would urge resident doctors who are taking part in strike action to do the right things. I'm sure many of them will. Jim?
I better just check with the chair, because I'm out of my allotted time, Jim.
No, you've got another 51, 52.
Bring Jim in then on that one.
So just to add to that, I lived through this as a trust chief exec, in the last few rounds of it. It's first of all, to reiterate what Secretary of State said, everybody respects the right to strike, but this is hugely disruptive, much more disruptive than we've been able to describe so far. I've worked with all the consultant colleagues at the end of a week when they've been working very, very long hours through the night to keep the service going. I've met with families who've had diagnostic processes cancelled 3 or 4 times because of strikes. And a lot of this narrow definition about what's technically necessary, I don't accept. It's not that straightforward, and we won't be accepting that kind of process this time. So really hope that this is avoidable. But we also can't allow this to play out in the way that it did last time, with a huge impact on people's lives, colleagues working in the service, a cancellation and a disruption of clinical pathways that is very hard to quantify the impact on. So I would just say, let's not just get too focused on the impact on the elective list. There's a whole range of other disruption that comes with this that we must avoid at all costs.
Thank you.
Thank you for that line of questioning. Can I move swiftly over to Greg, please?
Thank you very much, Madam Chairman, and good afternoon, Secretary of State. Unfortunately, I shall be continuing some of the line of the questioning. Can I characterise your view, therefore, on the strikes, that the strikes prior to the general election were reasonable, whereas the ones after the general election were unreasonable? Just a yes or no.
Well, I felt that the previous government was unreasonable by refusing to sit down and negotiate with the BMA for extended periods of time.
Yes?
I think the strikes before the general election were avoidable.
So what do you think has changed with the BMA to change them from a reasonable organisation to an unreasonable one? I suppose what I'm saying is, what have you done or not done?
Oh, I didn't say the BMA were entirely reasonable throughout the entire period.
Well, what have you done
keeping with their history, but
what have you done or not done, Secretary of State, that has made them come to this point of view?
Well, look, as far as I'm concerned, we've done the right thing. We came in. The strikes have been ongoing for a considerable period of time, at great cost to the taxpayer and at great cost to patients. We recognise the arguments that they've been making about pay erosion and about the conditions that resident doctors were working in, and we recognised the pressure they were feeling as doctors at a particularly early stage in their careers. And so I was proud of the deal that we did last year, proud of the decision we took again this year to implement the recommendation of the pay review body. Taken together, that's a 28.9% pay increase. And I would have expected, not unreasonably, that the BMA and resident doctors would think, OK, we might not have got everything we asked for, but we've moved considerably in the right direction. And this is a government we can do business with, as other trade unions do. We are, in the Labour Party, we're used to dealing with trade unions. Our history is anchored in the trade union movement, and we don't always agree with trade unions, even those affiliated with the Labour Party. But we do understand the value of trade unionism and the importance of deals and bargaining. But I don't see a reasonable kind of trade union partner in the RDC section of the BMA at this time, and I hope
but isn't that
will
part
change.
of the problem, Secretary of State? Isn't the problem that you gave them a massively inflation-busting pay rise, you asked no increase in productivity or efficiency from them, so essentially they've just come back for more? Do you accept no responsibility whatsoever for the position we're now in?
Well, firstly, I don't hold resident doctors responsible for the sort of the productivity challenges we have in the NHS. I think actually there are many aspects of the way that they are treated at work which are fundamentally unproductive. So I don't regret the deal that we struck with resident doctors. I do regret that they are in danger of squandering the opportunity of partnership in favour of a more adversarial approach, which is unnecessary, and I fear will prove self-defeating, because if these strikes go ahead, with the financial costs that are entailed, not to mention the misery inflicted on patients, we have to find that money from somewhere, and that will come at the expense of things that they value.
I think you've made that point clearly, Secretary State, and I suggest we all agree with that point of view. In December 2023, you noted that the then government was giving a higher pay rise to doctors than it was to nurses, and you said it was, and I quote, completely wrong, a slap in the face to nurses, and it seems to me fundamentally unfair. So if the nurses went on strike, would they be being reasonable or unreasonable?
Well, I hope that we're not going to get to that position with nurses, not least because we do have a reasonable dialogue and relationship with the Royal College of Nursing, Unison, and others in the agenda.
I hope we don't get there either, but if we do get there, Secretary of State, would they be being reasonable or unreasonable, given your own previous comments on this issue?
Well, we're working with those unions on agenda for change, pay structure reform. That's what we've agreed to do. I think so long as we fulfil our end of the bargain, then everyone will be happy and we can move forward building on that progress. If this government breaks its commitment to nurses and agenda for change staff, I think they would be rightly and justifiably angry, which is why we're not going to do that.
So, given that, as we heard in front of this committee some months ago from the then CFO of NHS England, most of the amount of money that's been put in this last budget was eaten up by pay rises, inflation, drug costs, etc., and therefore there isn't a vast amount of money left. Will you commit to having no above inflation increases to any health staff during this Parliament?
Well, we firstly have an independent pay review body process. I think that process is working largely well. I recognise that trade unions have a number of criticism about the way the process works, and I'm always happy to talk to them about how the process could be better. I thought, for example, the criticism that the PRBs reported far too late in the year was not just a frustration felt by unions, but felt by me too, which is why
I suppose what I'm trying to get to, Secretary of State, is what your view on this is. I mean, I understand the processes, but what's your view? Do you think the public sector NHS staff should get an above inflation increase over the next few years or not?
Well, we always take into account the recommendations of the pay review body. What I would say to NHS staff is the best way for us to be able to deal with the pay erosion they've suffered over many years and to make sure that we have a competitive rate of pay for NHS staff and a decent standard of living for all of our staff is to make sure that on reform and productivity we're going as hard and as fast as we can. And that's why we've had to make some decisions on things like the abolition of NHS England and bringing ICBs and systems back to balance, which at the moment are causing considerable pain for people involved in that decision-making process. And anxiety,
I don't need to cut
but
you
that's
off,
why we have to make some of those choices.
A small amount of time. I want to ask you about one other subject. So the Darcy report, the Darcy report that you commissioned said the dire state of social care is among the reasons that the NHS is in a critical condition, and you said at the Labour Party conference there is no solution to the crisis in the NHS that doesn't include a solution for social care. So why has there been really pretty much no inclusion of social care in this 10-year plan?
I don't quite accept that characterisation. So social care features insofar as it impacts on the NHS. So we would envisage social care being part of the neighbourhood health ecosystem. Much of the care delivered in people's homes will involve partnership with social care. In fact, we want to upskill the social care workforce to be able to undertake certain health tasks that we think under proper training they could undertake, would have to be supported with better pay. Delayed discharges, really big role for social care to play, and I would expect NHS organisations to look when commissioning intermediate care accommodation for admission avoidance and accelerated discharge, that we'd be buying more capacity with and through social care. So that's how social care featured in the 10-year plan. But of course there is a Casey Commission. Report 1 is out next year, and then the second report will be out subsequent to that. It's out the long-term direction.
Well, that nicely brings me on to the Age UK, what Age UK have said, and they say delaying the process of comprehensive social care reform will only make it harder to restore the NHS back to health in this Parliament or even the next. Don't you accept, as Age UK seem to be suggesting, that kicking social care to the end of this Parliament by increasing national insurance contributions on the vast proportion of the social care sector is actually hindering social care and therefore will have an impact on how deliverable your 10-year plan is?
Well, I don't agree with kick the can down. Since coming into government, and we've only been in a year, we have increased the spending power in social care significantly. We have delivered the biggest expansion of the carers allowance since the 1970s, a big increase in the disabled facilities grant. We've legislated for fair pay agreements. The Deputy Prime Minister and I will be setting out shortly how they will work in practice and how we're going to roll them out. So that's quite major improvement. I'm not pretending for a moment it's a panacea. I'm not pretending for a moment it's a panacea, but those are meaningful, demonstrable steps in the right direction, and there is more to come.
I will. I'll leave it there because I'm sure the chair wants to come in. Final question from me. I have a number of health-related concerns within my constituency of Farnham and Borden. Will you be willing to come and meet some of the doctors and patients in my constituency to hear their concerns?
If the diary allows.
I'll take that as a maybe. Thank you very much, Chairman.
Not that in there, Jeff. Okay, over to you, Ben. Thank you, Jeff, for your line of questioning.
Secretary of State and Jim and Sally, thank you very much for coming today. And it's just been a fascinating read, and also a nice read in large print, which makes a change. The separate government document actually makes it easier to read. I just want to talk a little bit about equality, and particularly race inequalities and inequity as well, which of course is different from inequality. It's excellent that the 10-year plan references inequalities and to see the determination to improve matters there. But it says relatively little when it comes to ethnic or race inequalities. And you'll be aware that we've been looking at this as a committee. The work we've been doing on maternal health, it shows quite serious differences. More black women die in childbirth, as the 10-year health plan references. More black children die in childbirth, at least twice as many. There are lots of examples of that. Do you think that there should be more in the implementation plan which you're bringing out about tackling racial inequality, particularly structural racism in the NHS, than there is in the 10-year plan itself?
Yes, I mean, I think, unfortunately, this is a huge issue in the NHS at every level. If you look at the experiences of Black and Asian staff, if you look at the experiences of Black and Asian patients, even adjusting for class inequalities and social determinants, we are seeing unequal outcomes for patients. We're seeing bullying of staff, which actually, when you think about how long we've had Black and Asian staff in the NHS since the beginning of the NHS, I think it's just completely intolerable. We don't have enough Black and Asian faces around executive and non-executive boards across the NHS, and that culture flows right down. In the work that I've been doing on maternity, obviously the black maternal mortality gap has been well publicised, and should be no less shocking to us now than the fact we've become used to those statistics. But what I was really, really shocked by, talking to some of the victims of NHS maternity scandals, were the patients who described, and patients and survivors, I should say, being described as a kind of a problem. One woman told me that she had been told, well, I thought you were a strong black woman, as an excuse for the fact she hadn't received enough pain relief. Yep. Asian women described as divas. And so, yes, there are health inequalities that need to be tackled, and some of that is about public policy, some of it is about social determinants, and the sort of the wider inequalities and things like genetics, disposition to certain disease and all the rest of it. We've got to deal with that using good science and good quality care, but that does not explain just the overt as well as unintended or unconscious racism that we see in the NHS.
So given that, and it's very interesting you talk about within the NHS, and I've been looking at the figures for the staff surveys which are published for 150 NHS organisations over the last few years. And it is quite shocking because the figures for 2022 on whether you feel that you have had fair career progression, whether you've been discriminated against by patients, whether you've actually, or other members of the public, whether you've been discriminated against by other members of staff, have actually got worse in the last 2 years. Jim, is this something you recognise and something that you have ideas about how you want to tackle it?
Yeah, absolutely. So this will be something we really want to elevate in this next phase. So from a staff satisfaction perspective, but also patient satisfaction perspective, and try to get behind these metrics and really understand what's driving concerns and how people feel like they're treated.
Do you think, given the fact that the figures have got a little bit worse over the last 2 years, and actually all the time I've been looking at it, which is over a number of years, they get a little bit worse each year. Do you think the NHS doesn't have an idea how to tackle it? And if you do, what would you think it could do differently?
I think pockets of the NHS have. I think there is evidence where organisations have been very systematic about understanding the data, really tailoring that to local